Hi friends, today we will be discussing about the approach to anemia. As per WHO criteria, anemia is defined as Hb less than 13 grams per deciliter or hematocrit less than 41% in men, Hb less than 12 grams per deciliter or hematocrit less than 36% in women, Hb less than 11 grams per deciliter in children and Hb less than 10 grams per deciliter in pregnant women. This is as per WHO criteria. Anemia in India, as per vulnerability, may be divided into various population. Like children under less than 5 years, they account for 58%, almost 58% of the anemia. Women in the reproductive age group, they include 53.1%, and pregnant women, they account for 50%, and men account for 22.7. Means children under age of less than 5 years, they are more vulnerable to anemia. The patient with anemia usually presents with the weakness, shortness of breath, dizziness, fast or irregular heartbeats, lethargy, headache, cold hands or feet, pale skin, chest pain, and signs maybe include pallor, pale skin, blue sclera, atrophic glossitis, chillosis, koilonychia, esophageal web, and alopecia. This picture depicts the patient of anemia with pallor. However, the pallor can be seen in hypothyroidism, pituitarism, hypoglycemia, shock, and malignancy. And blue sclera, it is also very common in anemia, and blue sclera can be seen in the patient with high myopia, osteogenesis imperfecta, pseudoxanthoma elasticum, Ehlers-Danlos syndrome, scleritis, and buphthalmas. Here you can see the patients of anemia with glossitis. The tongue, you can see that it is pink or red shining with loss of papillae. And glossitis can be seen in allergic reactions, infection, injury, or some hormone or vitamin deficiencies. Similarly, the patient's anemia can have esophageal webs. Esophageal webs is common in iron deficiency anemia, autoimmune and developmental disorder, inflammation, and gastroesophageal reflux disorders. Here we see spooning of the nails. It is called koilonychia. It is very common in iron deficiency anemia. However, the autoimmune disorder like SLE, psoriasis, lichen planus, genetic diseases like hemochromatosis, nail patella syndrome, CVD or PVD, nail trauma, hypothyroidism, they can also present with the features of koilonychia. Angular chillosis, angles of the mouth, they are involved, and we can see there is cracks at the angle of the mouth. It is also seen in infection, nutritional deficiencies, dermatitis, and it can be seen as a side effects of some drugs. So the approach to anemia will include first of all the CBC, that is a complete blood count. The complete blood count will include red cell count, hemoglobin, hematocrit, retic count, and red cell indices like MCV, that is a mean cell volume, MCH, MCSC, SC, red cell distribution width, white blood counts with their differential nuclear segmentation of neutrophils, platelet count, cell morphology, which is actually PBS, peripheral blood smear, which will tell us about the cell size, hemoglobin content, anisocytosis, poikilocytosis, polychromasia. Then we have also to do iron studies like serum iron, total iron binding capacity, serum ferritin. These help us to differentiate the iron deficiency anemia from anemia of chronic diseases or other diseases also. And last but not the least, we can uh, we can also do the bone marrow examination, which I will discuss in later slides, and biopsy. So the stepwise approach to anemia will be on clinical examination, sign and symptoms. If we suspect the patient is anemic, we have to do his uh, HB, hematocrit, Paxil volume, RBC counts, and we have to rule out in step 2 whether the RBCs are microcytic, normochromic, normocytic, or macrocytic, and this can be evaluated from the mean corpuscular volume. Is the anemia hypo or normochromic? That will be shown by MCH. And in the next step, is the disease RBC product, is there is decreased RBC production or increased destruction or loss? Because if there is decreased production of the RBCs, increased destruction or loss, that will be shown by the reticulocyte count, and it is important determinant for diagnosis of anemia. Is the anemia with normal or abnormal RBC morphology? That will be cleared from our peripheral blood smears. And if we are not sure about the etiology of anemia, we have to uh, do the bone marrow examination. Functionally, we can classify anemia based on its production defects, maturation defects, or their survival defects of the RBCs. If there is maturation marrow production defects, then we will have a hypoproliferative bone marrow. If red cell maturation defects are there, we call it as ineffective erythropoiesis. And if the patient has history of blood loss or hemolysis, it will be shown by the decreased red cell survival. So whenever the patient of anemia comes to us, if we see his HB is low as per his age, sex or race, then we have to evaluate whether he is truly having anemia or not, whether other cell lines like leukocytes and platelets, they are also affected or not. If yes, then we have to check for his MCV, means that is mean corpuscular volume. If the patient has low MCV, then there are likely chances that the patient has iron deficiency. If patient has low MCV, there are likely chances that patient has iron deficiency anemia, thalassemia, sideroblastic anemia, anemia of chronic diseases. Means low HB, low MCV, we should suspect of iron deficiency anemia, thalassemia, sideroblastic anemia, or anemia of chronic diseases, and further evaluation and confirmatory tests are needed to rule out all these four categories. We will review the dietary history. Therapeutic trial of iron can be given. We have to do his iron studies like serum iron, TIBC, serum ferritin, and hemoglobin electrophoresis. If the patient's HB is low but MCV is high, low HB, high MCV, then the causes can be drugs like anticonvulsants, zidovudine, methotrexate. We have to take actually history whether the patient is taking some anticonvulsant for epilepsy, zidovudine, that is a antiretroviral drug, methotrexate for rheumatoid or other rheumatic disorders, and we have to ensure that the patient has vitamin B12 deficiency or folate deficiency, sickle cell disease, especially if treated with hydroxyurea, immune hemolytic anemia, diamond blackfan anemia, liver diseases, and hypothyroidism, post splenectomy anemia, myelodysplastic syndrome, reticulocytosis, means high reticulocyte count. These are the condition uh, which lead to increased MCV, means drugs, vitamin B12 and folate deficiency, sickle cell anemia, immune hemolytic anemia, liver disease, hypothyroidism, post splenectomy, myelodysplastic syndrome, reticulocytes counts. So in such patients, we have to review their peripheral blood smear. In peripheral blood smear, if they have hypersegmented polymorphonuclear cells, means neutrophils are hypersegmented, then possibility of vitamin B12 and folate is there. Secondly, if we see spherocytes, then autoimmune hemolytic anemia chances are there. If sickle cells are there in PBS, rule out sickle cell disease. If there are Hubble jowl bodies, then patient may have post-splenectomy or status or asplenia. So such patient will need further evaluation and confirmatory test, like we have to review their medications, we have to properly take their dietary history, whether they are vegetarian, non-vegetarian. We have to do their serum vitamin B12 and folate level, thyroid function tests, osmotic fragility for spherocytosis, hemoglobin electrophoresis, that bone marrow biopsy and aspirate. These are basically the confirmatory tests if the patient presents with low HB, high MCB, and with their PBS suggestive of hypersegmented polymorphonuclear cells, spherocytes, sickle cell disease, sickle cells or Hubble jowl bodies. We have to later all these. We have to later do all these investigation, like as mentioned here: serum vitamin B12, folate, thyroid function test, osmotic fragility, hemoglobin electrophoresis, bone marrow, aspirate, biopsy, that. If the patient has low hemoglobin but his MCB is normal, then we have two options. We have to do his reticulocyte count. What is the reticulocyte count that can be obtained if we ask for peripheral blood smears? If that is low or normal reticulocyte count, we will have two options. We will get two types of responses for reticulocyte response. Whether that will be low or normal reticulocyte count, that is less than 2.5%, or it will be more than 2.5%. So if the patient with low HB, normal MCB, with low or normal reticulocyte count uh, comes to us, we have to suspect about these possibilities that the patient may have infections, um, that anemia may be because of infections, drugs, lead poisoning, acute blood loss, anemia of chronic diseases, renal diseases, and total TEC. TEC is a transient erythroblastopenia of childhood. Okay, if the patients with low HB with normal MCB comes, we have to do his reticulocyte count. If reticulocyte count is low or normal, that is less than 2.5%, then the possibility of infection, drugs, lead poisoning, acute blood loss, anemia of chronic disease, renal diseases, and TEC is there. We have to review their smear. We have to look for toxic granulation, bandemia, atypical lymphocytes. All these show the possibility of infection. And if we find basophilic stippling, the chances of lead poisoning are there. And further evaluation and confirmatory tests are required for further evaluation. These may include a review of their medications, bacterial culture and or viral studies, serum lead levels. We have to do their bone marrow biopsy and aspirate studies. So the second possibility will be if the patient with low HB, normal MCB, with high reticulocyte count, that is less than more than 2.5%, then there are chances of hemolysis. So we will look for any evidence of hemolysis. If there are any evidence of hemolysis, if answer is yes, then the possibility of hemolytic anemia is there. So we have the possible causes of hemolytic anemia will be membranopathies, enzymopathies, hemoglobinopathies, autoimmune hemolytic anemia, microangiopathic hemolytic anemia, and membranopathies like hereditary spherocytosis or elliptocytosis, enzymopathies like G6PD deficiency, pyruvate kinase deficiency, hemoglobinopathies like sickle cell disease, autoimmune hemolytic anemia, microangiopathic hemolytic anemia like hemolytic uremic syndrome, thrombotic thrombocytic penic purpura, DIC, Casabeck-Merritt syndrome, artificial heart valves, all these causes microangiopathic hemolytic anemia. So patient with low HB, normal MCV, high reticulocyte count, we should think of hemolysis. If there is evidence of hemolysis, then the chances of hemolytic anemia are there. And so the causes of hemolytic anemia are membranopathy, enzymopathies, hemoglobinopathy, autoimmune hemolytic anemia, microangiopathic hemolytic anemia. If there is no evidence of hemolysis, then chances of hemorrhage are there. So if we are looking for if there is possibility of hemolysis, we will further rule out with the review smear. In the review smear, we will look for spherocytes. Like spherocyte, if we find spherocytes, then the chances of hereditary spherocytosis or autoimmune hemolytic anemia are there. If we find fragmented cell in peripheral blood smear, then the chances of microangiopathic anemia. If we find sickle cells, then chances of sickle cell disease are there. If we find leptocytes, hereditary leptocytosis. If we find Hinz bodies, then the chances of G6PD deficiencies are there as a cause of this anemia. So such patient needs further evaluation and confirmatory test. And for the confirmation of this hemolytic anemia, we have to do indirect bilirubin, LDH levels, haptoglobin levels, that G6PD screening test, osmotic fragility, hemoglobin electrophoresis. That is basically direct antiglobulin test. It is usually done for hemolytic anemias. Please remember these slides by heart, and these are very useful for evaluation of anemia. Physiological classification of anemia is usually done with the CBC and the retic count, and from the retic count we find out the reticulocyte production index. I will come before going to this. Let me discuss about how we calculate the reticulocyte production index. The reticulocyte production index, we give at least two correction, and actually this is calculated by the formula. We must have hemoglobin, hematocrit, and normal hemoglobin level values in a person of that age and sex. This correction produces a normal corrected reticulocyte count. A person, for example, whose reticulocyte count comes 9% and his hemoglobin is 7.5 gram and hematocrit is 23. The absolute reticulocyte count, first we have to calculate absolute reticulocyte count. It will be 9. Means first of all, it is patient's retic count into patient's hemoglobin divided by hematocrit. That will be patient's retic count here is 9 into hemoglobin is 7.5 and hematocrit hemoglobin is hemoglobin divided by hemoglobin of that sex and age, normal hemoglobin of that sex and age. So for this, the hemoglobin will be normal hemoglobin is 15. So we get the reticulocyte count. If we don't know the if we are given only hematocrits of the patient, then again we will do like this: retic count of the patient into hematocrit of the patient divided by normal hematocrit. So in here retic count is 9 into hematocrit is 23% and the normal hematocrit is 45. So we will get either from this method, this by taking hemoglobin, or by taking hematocrit, we will get the reticulocyte count, correct, so absolute reticulocyte count as 4.5%. Let me again clear. So the absolute reticulocyte count is reticulocyte count of the patient multiplied by hemoglobin of the patient divided by normal hemoglobin of that sex or that age as per their normal values. And similarly, if we know only the hematocrit and reti count, then again absolute reticular count will be reticulocyte count of the patient into hematocrit divided by normal hematocrit of that age and sex. Okay, so here we get 4.5% as the absolute reticulocyte count. Since we know that average lifespan of an RBC is 90 to 120 days, but the reticulocytes they die prematurely in anemic patients. So again we give another correction, and that correction is given as we have to divide this absolute reticulocyte count by another maturation factor of 2. Okay, this will give us the value of reticulocyte production index. So our the reticulocyte production index is absolute reticulocyte count divided by 2. This will give us reticulocyte production index, and this reticulocyte production index help us in further physiological classification of the anemia. So coming to the next slide. So in physiological classification of the anemia, if we only have CBC and reti count, we have to first find out the reticulocyte production index, RPI. And in the previous slide, as we discussed, that RPI is reti count divided by 2. If the patient has reti count of 5, we have to divide it by 2. Any reti count divided by 2. If that reticulocyte production index comes below less than 2.5, or if it is more than 2.5, if it is less than 2.5 means reticulocytes are produced in a very minute quantity, means there is inadequate production of the reticulocyte count. And if it is if index is more than 2.5%, it means there is massive production of reticulocyte, or there is excessive destruction of the reticulocytes. Because reticulocytes, they will be, if they are produced damaged, so they are produced in a very aggressive manners. They are produced in a huge quantity, but they are at the same time they are being destroyed also. So the classification of anemia as per reticulocyte count will be, we have to first calculate the reticulocyte production index, RPI, and that I told you in the previous slide how to calculate the reticulocyte production index. If it is less than 2.5, then the chances of hypoproliferative marrow are there. If it is more than 2.5, then the chances of hemolysis or hemorrhage are there. So if the reticulocyte production, coming to the physiological classification of anemia, as we discussed that if the patient comes with anemia with low hemoglobin, and if we know his reticulocyte count, we have to first calculate the reticulocyte production index. And if it is low, means it is less than 2.5, or if it is more than 2.5. If it is less than 2.5, then we have to see in peripheral blood smear the red cell morphology. If in red cell morphology is normocytic, normochromic, then the chances of hypoproliferative disorders are there. We have to rule out marrow damage, and marrow damage, decreased stimulation of the bone marrow. The marrow damage may be due to infiltration, due to malignancy or fibrosis, aplasia, iron deficiency, understimulation due to inflammation, metabolic defects, renal diseases, hypothyroidism. If the red cell morphology is suggestive of micro or macrocytic picture, we have to look for maturation defects or nuclear defects. Maturation defects or maturation disorders. In maturation disorders, we have cytoplasmic defects and the nuclear defects. And in cytoplasmic defects, we have to see rule out iron deficiency, thalassemia, sideroblastic anemia, and nuclear defects, they usually will be due to folate deficiency, vitamin B12 deficiency, drug toxicity, or myelodysplasia. So if reticulocyte production index is less than 2.5, the chances of hypoproliferative or maturation disorders are there, and these are the various causes which are responsible for hypoproliferative disorders and the maturation disorder. However, if the maturation is this reticulocyte production index is more than 2.5, then more than 2.5 or equal to 2.5, then the chances are hemolysis or hemorrhages are there, and the causes of hemolysis or hemorrhage are blood loss, intravascular hemolysis, metabolic defects, membrane abnormalities, hemoglobinopathies, immune destruction disorders, fragmentation. You understood the approach to anemia. Please read Harrison, Internal Book of Medicine, 20th edition, or any updated version of Harrison for detailed anemia evaluation. Thank you very much.